Hello and welcome to the American Journal of Psychiatry Residence Journal podcast. My name is Carol Chan and I'm the Associate Editor for the Residence Journal. Our guest for today's show is Dr. Paul Nestadt from Johns Hopkins. Dr. Nestadt is an assistant professor at the Johns Hopkins Department of Psychiatry. He completed his psychiatry residency at Johns Hopkins. His research focuses on the epidemiology of suicide, specifically the role of firearms in opiate access and the increasing rates of suicide. So thank you so much for being here today. So I just want to start by asking how you got involved in this area of research in psychiatric epidemiology and what drew you to this area of research.
Well, I guess I first got interested in suicide and the epidemiology of suicide when I was a resident working in the ER. As most of the people listening know, when you're a resident, maybe one of the most high-stakes roles you have is the ER psychiatrist, where you're making the call whether to admit somebody, whether you think that their suicidal ideation is serious enough that they need to come into the hospital, use up one of those valuable beds, or if they can maybe be treated outpatient, and you can set up an appointment and send them to an outpatient doctor. And we would make those decisions, as everyone does, on a regular basis, based on a variety of factors like their illness, their symptoms, maybe even their demographics might play a role because we know of the higher risk populations. And then we would say, okay, this guy needs a bed, this guy doesn't need a bed, and then never really know if we made the right decision, right? If you admit somebody, they'll get treatment and great. If you discharge and that person goes on to die by suicide over the next few days, you might never know. In fact, you would never know. And that bothered me because I realized that everyone in my class, based on their personality, would either go home at the end of the day very confident they've made the right decisions or be nervous about it. And we would never learn from any mistakes we might make. So if you're a surgeon and you notice that people are getting more infections when you cut one way or the other, you might adjust your practice. But for us, you could work in the ER for 30 years, and since there's no feedback, would get no better at making that call. So I wanted to find out if anybody that I had seen had died by suicide, and the only person that would know that would be the medical examiner. So I called him up. I went down to the ME's office and just basically cross-referenced my patients I'd seen in the past month on the service with his patients. And luckily there was no overlap, but as I looked through his records of people that had died by suicide, a lot of them looked like the kind of people I might have discharged. I still remember the very first folder that I opened. This was, they're hard files. And the first page is a photo of the crime scene. So in this case, as in many cases, it's frames on the wall. Some guy had shot himself in the head. And reading the description, the clinical description that they gathered from the police and the ME, he had, just was fighting with his girlfriend. He had cheated on his girlfriend, and she had caught him. And so she confronted him and he said, baby, if you leave me, I'm going to shoot myself. In sort of a arguably kind of, personality disorder way, like sort of just like making it about him. And she thought he was bluffing. She left. And as soon as she closed the door, she heard a shotgun go off and he killed himself. It made me, for the next few rotations in the ER, basically admit everybody. I got really scared. So I wanted to know more about who was really at risk, especially in my local area. I mean, like a lot of those studies, they're done, the Scandinavian countries or the VA system. I'm in Baltimore, where the population doesn't look like the Midwest, where most of those studies happened. And so I wanted to know who was more at risk. So I started working with the medical examiner. We collaborated on looking at large swaths of data that he had on every suicide in Maryland, and that's where it started.
Is that usually how most suicide epidemiology study is done? Or are there, through a medical examiner, or are there other ways?
That's a good question. There's lots of ways to do it. Most people that are looking at the big data in the U.S. on suicide are using the NVDRS, the National Violent Death Reporting System data, which is affiliated with the CDC. There are certain states, I think we're up to 28 states now, that report all violent deaths through a unified form so that anyone can just Google CDC Wonder or all these large data sets that show national data on suicides, and they can download them and chop them up. I like working with the Maryland data because suicide data is not always very cut and dry. So even determining whether someone is a suicide or not, whether this was the cause of death, whether it was intentional, is complicated. There's a lot of political factors. And the people that make that determination, some of them are coroners, some of them are medical examiners. In Maryland, we have a statewide medical examiner system. But other places have coroners who are appointed. Many of them have a high school diploma and nothing past that. They're just sort of elected officials that, maybe their father and their grandfather's coroner. So they're more influenced by political pressures that might be there. A family saying, hey, it wouldn't look good for us if this was seen to be a suicide. And then they might, just fudge whether it was or not. In Maryland, if the ME, Dave Fowler, says it's a suicide, you can be pretty sure it was. Everyone gets the same protocolized autopsy. Everyone gets full toxicology. It's a good investigation. So I like local data where I know what I'm dealing with. But for bigger data, it's out there.
And so after residency, did you go for fellowship to pursue this type of research?
I did, yeah. I graduated from residency here at Hopkins, and then I did a 3-year psychiatric epidemiology training program, which is a T32 program funded by NIMH to really learn more data analysis techniques that I wasn't as familiar with. So I needed to learn. I had used SPSS a little bit when I was in college, and I'd actually been a brain imaging researcher, like research coordinator before med school. But I needed to learn Stata, and I needed to learn R, and so I needed classes. So I spent 3 years learning that stuff, and also working with non-clinicians that, the real researchers who could help me as I was learning.
Yeah, and be able to, I guess, translate some of the findings to clinical application.
Yeah, and it's good to have someone who really knows study design better than I did at the time to look over what I was doing and making sure I wasn't doing anything stupid or saying anything wrong.
Great. So in the years of research that you've been doing on the suicide epidemiology, are there things that you have found that surprised you were interesting?
Yeah, there's a lot of places where the literature diverges from what I think is our standard clinical practice. One issue that I've spent on my mind lately is suicidal ideation as a concept. So in the ER, here at Hopkins, and I'm sure most places, whether someone has SI is really one of the major indicators of whether they need to still be in the ER or if it's time to discharge them. Very common practice, if somebody does not report any ideation, we often just let them go. Or if they do have ideation, we see that as the biggest red flag. Suicidal ideation does predict future suicidal ideation, but there's no evidence that suicidal ideation acutely predicts actual suicide completion. And we use that as sort of the biggest indicator. So that's something that I think has consequences. So one of the consequences of us overvaluing SI as a predictor, suicidal ideation as a predictor, is the universal screening guidelines. So JACO back in, I guess it was February of 2016, released Alert 56, where they recommended that every hospital screen every single person for, as they put it, suicide risk. But in reality, they're recommending screening for suicidal ideation. And that led to many hospitals, every hospital, starting to screen everybody. And then if someone denied suicidal ideation, well, the assumption is that they're safe, which is not a safe assumption. And if they endorsed it, then they were seen as being at risk when in fact there's no indicators that there's any positive predictive value for completed suicide from suicidal ideation. So that's one thing that came up. The other thing was guns. I mean, guns were by far seem to be the only thing that people have shown over and over again to actually decrease suicide rate is addressing the gun issue. In the U.S., about half of suicide completions are by firearm. 2/3 of firearm deaths are suicides. They're linked, and we've found that in areas that have more guns, we have more suicide. When we've decreased access to guns, we've seen less suicide in a way that even increasing access to mental health care hasn't been. And as a psychiatrist, I'd like to say that the best thing you can do is get more psychiatrists out there, treat people. That is important. But the intervention that's really decreased the number of deaths has been decreasing access to guns. And that was surprising to me.
Yeah, I think one of the scariest things I've learned as a third year, kind of going back and reading more of the literature on psychiatry, is that it's hard to predict whether someone's going to act on suicidal thoughts. Like, we read a lot about how people who do go on to commit suicide actually don't tell anyone. And there are, of course, people who say that they have suicidal ideation and then don't, of course, go on to the suicide, whether that's because other theories have been put up or not. But the scariest thing that I learned in the last few weeks is just hearing how many patients don't tell anyone that they've been having these kind of thoughts.
That's true. We're terrible at predicting suicide. We're just terrible at it.
Yeah. Has anything that's come up in your research changed the way that you practice?
I guess that, if anything, it's made me more cautious. Just if you're looking at suicide records, if you're looking at the records of people that did die by suicide, you start to project to everyone that you're interviewing, like, oh, this looks a lot like, this patient that I'm seeing that isn't someone that used to have worried me, looks a lot like, a pattern I might have seen in the data, and I might even overcall it, but I'm certainly on the more cautious side. You hear this a lot from clinicians who have lost a patient to suicide, that in the years or maybe forever following that, they're just more cautious. it's not really an evidence-based reason to be more cautious, but that's human nature. I think the same thing is happening to me. As far as I know, I haven't lost a patient to suicide. It's very possible that I haven't, don't know it. But because it's something I think about a lot, suicide's something I think about a lot, I think I'm a more cautious clinician these days.
So you mentioned firearms, and another kind of hot topic in psychiatry and public health is substance use or the opiate epidemic. Have there been any studies into what kind of role it has? Are there changes in the type of substances we're finding that are associated with suicide?
Well, of course, opiates play a role in depression, which is one of the most important risk factors for suicide. The other big risk factor being substance abuse itself. So as opiates become more prevalent, we are seeing more opiates involved in suicides, and we're seeing, you could argue that maybe the increase in suicide over the past 18 years may be related to increase in opiates. It's hard to say. There's an ecological problem. But it's clear that opiates can contribute to depression. It's clear that 80 to 90% of people that die by suicide have depression. So that's a connection that's hard to deny. And also, just like guns, opiates are a potential lethal weapon. It's something that more and more people have opiates in their closets these days from their wisdom teeth operation or whatever. They're just sitting around more often. People are prescribing opiates in high amounts. And so then those become something you can use to die in a very lethal and convenient way. So they're being used. I believe that a lot of the deaths from opiate overdose that are being called accidents or of undetermined manner, especially here in Maryland, may really be suicides. And there's been some good research that people like Ian Rocket have done, looking at how we can figure out which of these deaths that aren't called suicides really are, so we have better epidemiologic data so that we know the different pathways to death. It's not always someone that uses opiates for reasons of dependency or pain control, accidentally overdosing just on a whim. Maybe some of them have some intentionality. It's probably a spectrum, and then maybe many of them actually do want to die. It looks like maybe 30% of the opiate overdose deaths that are called undetermined, which is a lot of them. In Maryland, it's something like 85% of opiate overdose deaths, may really be suicides. And that's worrisome. And if that is true, then we need to be targeting our interventions appropriately. The way that you target people that are dying by suicide is different in some ways than how you would target people that are just dying because of a dependency that accidentally leads to death. So I'm interested in that a lot. And the way I think the only way we can ever figure that out is to do in-depth psychological autopsies on a subset of people that are undetermined deaths to see which sorts of decedents might be more accurately classified as suicides, and targeting interventions based on that.
Suicide's been in the news a lot the last few months with several very famous people committing suicide.
Sure.
And there's also been a lot of talk about how suicide is reported in the community and how that information is disseminated, whether that results in copycat suicides. Do you have any thoughts on?
Yeah, I think that can be a big problem. Some people refer to this as the Werther effect because of a very famous case that I think helps paint a picture of what copycat suicide can be like. But the fact is that when there is a suicide covered by the media in sometimes the wrong ways, people that are vulnerable in the community see that representation of suicide as more attractive, more doable, more available. So if you see someone, especially a celebrity, who people look up to, who seem to have everything going for them, dying by suicide, it makes it seem like a viable option to many people. Because of that, we try to discourage the media from speaking about suicide graphically. Describing their methods is a terrible mistake. You then see when you have had methods described in the media, you often see increases in suicide by that method. It's also really important that when the media covers suicide, that they make sure to mention that suicide is a symptom of a treatable illness, that it's something that can be helped. Not, this person completed suicide, died by suicide because they needed to as a natural result of what they were going through, but rather, no, if only they'd gotten treatment. And by the way, if you need treatment, here's a suicide hotline number. Here's how you can approach treatment. Here's the success rates with treatment for depression. The media's getting a lot better at doing that kind of thing, especially in the news media. Where it's harder to convince people to talk about suicide in a more healthy way is in entertainment media. Very famously, 13 Reasons Why had come out with a story of a girl who had died by suicide and in a way had kind of weaponized her suicide to get back at those who had wronged her. You could imagine this being an appealing narrative to adolescents struggling with mood disorders or thinking about suicide. Like, oh, look how she won. It's dangerous. And the producers of 13 Reasons Why, when confronted with these mistakes, were very responsive. And my understanding is that for the second season, which came out recently, they had Madeline Gould and some of the other really skilled suicide researchers in the field of copycat suicide advise them, consult for them, and help guide the way that they presented their narratives in the future. But yeah, it's an important factor that needs to be considered.
Yeah, I think with 13 Reasons Why and suicide being in the news, it's been in some ways good for opening up conversations about depression, but certainly you have to be very careful about how some of the information is disseminated.
Yeah, absolutely.
So kind of wrapping up, because we're coming near the end of our time, do you have any advice for residents who are thinking about either going into psychiatric epidemiology or suicide epidemiology, like how to approach it or get started?
I think if you're interested in research, in big data research or epidemiology in general, the best way to get started is just to try to decide on something that you're interested in, maybe a problem you've noticed in the hospital. I talk to residents all the time who've wondered about things that they're doing clinically, wondering if there's evidence for doing them, and just collect data on it. And most people get intimidated by statistical analysis, but there's a lot of very simple things you can do, looking at proportions of patients. Or if you're working in an academic setting, you can often find researchers, non-clinicians, who are dying for a clinician to work with them, to give them a hypothesis to work on, or that have data that they want your input on. Clinicians are a hot commodity in the research world. So even if you don't have a lot of experience with the number crunching, someone else is happy to do that for you, to get your opinion. As a psychiatric resident, you have experience and thoughts that aren't common out there in the research world. Yeah, I think that would be my best advice.
Well, thanks so much for talking to us today.
Sure, it's a pleasure.